right. Gotta get used to Zoom again. Okay. I'm so used to Teams. All right. I think I will get started. I think I got everything. All right. So this capstone examines a significant organizational change that occurred within Essentia Health's quality department in 2018. So my name is Candace Sam, and I will be reviewing my capstone healthcare quality department redesign, expanding roles beyond nursing. So I specifically explored why the department was restructured, how responsibilities were reorganized, and how the quality partner role evolved from being a primarily focused nursing background to a competency-based position that welcomes professionals from multiple healthcare disciplines. The broader purpose of this project is to demonstrate how healthcare organizations can address workforce challenges while continuing to improve their quality outcomes, their regulatory compliance, and also the operational effectiveness. So I chose this because I actually went through the restructure and the change of the quality partner role as well. I started in 2018 with Essentia and experienced the restructure, and then went back and interviewed colleagues and analyzed it, and ended up with some recommendations and future things to go forward with it. Content overview. So I'm going to go over why it matters, the purpose of the project, the background and literature, Essentia Health before the change, looking at quality specifically, the new specialized quality structure and the redesign of the quality partner role, and then of course the results and impact with that recommendation. So the challenge facing healthcare organizations. Healthcare is an industry that is currently experiencing pressures from multiple directions. Organizations have to continue delivering that safe, high quality care while facing workforce shortages, growing patient demand, and increasing that regulatory requirement, along with a heightened expectation of quality and safety. One of the most significant workforce challenges is the ongoing nursing shortage. Because many healthcare quality positions have historically been filled by nurses, organizations often find themselves competing for the same talent needed at that bedside. At the same time, quality departments are being asked to do more than ever before. Today's quality professionals are responsible for accreditation readiness, quality improvement initiatives, data analytics, patient safety programs, process improvement, and regulatory compliance. As a result, healthcare leaders are increasingly asking important questions like, do all quality positions require that nursing background? Can these responsibilities be effectively performed by professionals from other healthcare disciplines? The question served as that foundation for my capstone project, and then also the organizational changes that occurred at Essentia. So three main opportunities or challenges: nursing workforce shortages. These are significant shortages, and they are expected to persist. Those increasing regulatory requirements, there's that pressure to deliver that care, but still managing complex asks of those regulatory requirements. And then the growing demand for quality improvement, like I said, still having to evolve, but make sure that it remains effective, sustainable, and aligned with strategic goals that the health system creates. So the objectives or the purpose of the project. The purpose of the capstone was kind of a twofold. So in 4 steps. First, I looked at Essentia Health's November 2018 quality department restructuring, specifically, wanted to understand the factors that led to leadership deciding this transition from a decentralized structure to a more specialized and centralized quality model. The second, wanted to evaluate the redesign of the quality partner role and explore the rationale for expanding that role qualification beyond the nursing background. So the project really looked into determining whether these changes improved operational efficiency, if it strengthened the workforce flexibility, if it enhanced quality support across the organization and contributed to the overall organizational performance. So ultimately, my goal is to evaluate whether the workforce diversification and organizational redesign could serve as that viable solution to the healthcare workforce challenges while maintaining those high standards of quality and patient care, which is the main angle. So what the literature says. My literature review identified 3 major themes that support the need for the organizational change. First being the healthcare quality departments. They evolved significantly over time. Historically, quality departments focus primarily on the regulatory compliance aspect and the accreditation activities along with patient events. Today, they serve as strategic partners and help improve patient outcomes, support the organizational performance, and promote that continuous improvement in multiple areas. The second, workforce shortages continue to challenge healthcare organizations nationwide. Research suggests that nursing shortages, like mentioned before, are expected to persist for many years due to burnout, retirement, and workforce circumstances. So these shortages highlight the need for healthcare organizations to rethink those traditional staffing models. And then the third, evidence-supported interdisciplinary workforce approaches and task shifting strategies. So multiple studies have demonstrated that appropriately trained professionals can successfully perform those responsibilities traditionally associated with other disciplines without negatively impacting those outcomes. So collectively, the literature suggests that competency-based workforce models may offer healthcare organizations that greater flexibility while still maintaining the effectiveness and quality performance. So prior to November 2018, Essentia Health's quality department operated within a decentralized structure. There were individual markets maintained significant autonomy and often developed local processes, reporting relationships, and those quality improvement activities. This model allowed the flexibility for individual facilities, but it also created variation across the entire system. So at the top, of course, we had the vice president of quality, and then we had system representation, but they were separated by each market that we had. So Central, East, and West. Central, each market had a director, each market had quality partners, and then also infection prevention specialists under them. So same structure, but separated by each market. So as Essentia continued to grow, it was recognized by leadership that inconsistency in quality processes could limit the organization's ability to achieve those system-wide goals, which is the real thinking that we were trying to move to. Is we're not 3 different markets working and doing processes differently. We're all one, and it needs to be consistent. There was also a desire from executive leadership and the board of directors to move from a holding company model toward a more integrative operating model. And with that, it was the change in the quality department. So this shift required a greater standardization, a greater collaboration, and more coordinated approach to quality management across the markets. So this existing structure was no longer fully aligned with the long-term strategy, and it became a primary driver for the change. And that was given to the vice president when hired, that was one of his achievements or goals that he needed to work towards. So the department restructure, the restructuring process occurred over approximately 1 year and involved extensive planning and stakeholder engagement. Leadership understood that organizational change can be disruptive. Therefore, transparency, communication, Relationship building were major priorities throughout that implementation. The transition was completed in phases rather than all at once. So leaders spent considerable time meeting with those stakeholders, discussing the concerns, making sure to build that trust, and explaining the benefits of that centralized approach. One of the key objectives was to standardize quality processes across the health system while maintaining staff neutrality. So the restructuring also created opportunities for that stronger leadership oversight and then improved alignment between quality initiatives and organizational goals. Overall, the redesign represented a shift from locally managed quality operations to a coordinated system-wide quality strategy. So this is what we changed to in 2018 to present, and this is just a very high-level overview. There's a lot more arrows to what we are today, but we still have our VP over the system. And then what changed was, even though we separated quality into two groups, hospital and ambulatory, which I'll explain more in the next few slides, they represented or worked with the entire system of Essentia Health rather than being separated into three different groups. So we had infection prevention that supported the entire system, which allowed the specialists to collaborate, to work together, to share best practices, same with the quality partners throughout the system, and keep things consistent throughout the entire Essentia Health as a whole. So we had ambulatory quality, which we have quality partners, and then a few other teams underneath. And then we also took on data abstraction, which includes physician quality and clinical data as well. Hospital quality versus ambulatory quality. So focusing just on splitting those up, one of the most important outcomes of restructuring was the creation of these specialized divisions. Leadership recognized that hospitals and ambulatory clinics operate in very different environments and faced very unique quality challenges. So hospital quality team focuses primarily on accreditation readiness, regulatory compliance, patient safety initiatives, and survey participation activities, which sometimes does include the clinics. But it's only looking at the regulatory patient safety things. Meanwhile, the ambulatory quality team focuses on performance measurement, quality metrics, pop health initiatives, clinic operations, and process improvement efforts. So creating these specialized teams allowed employees to develop a deeper expertise within their aligned area while supporting the broader goals of the health system. The new structure also improved accountability by clearly defining those responsibilities and the expectations for each division. This specialization became a key factor in improving operational effectiveness throughout the organization. It was also made so that employees within these two specialized divisions could grow within the department as well. So there was a director, and then entry-level quality partner 2, senior quality partner. So employees entering these departments or divisions also had opportunity to dive deeper into their expertise and then also grow within the department. Redesign of the quality partner role. So this was, along with the restructure of the department, this was also looked at. So in addition, leadership also reconsidered who could perform the quality work successfully. Historically, many quality positions required a nursing background. While nursing experience remains extremely valuable, leaders realize that many quality responsibilities require a broader set of competencies. So quality professionals spend significant time leading projects, analyzing data, managing performance metrics, facilitating process improvement initiatives, supporting regulatory compliance activities, and collaborating with interdisciplinary teams. Because of this, Essentia Health shifted from a credentialed focused hiring model to a competency-based hiring model. So rather than asking whether someone was a nurse, leaders began evaluating whether candidates possessed the knowledge, skills, abilities necessary to perform quality work effectively. This allowed individuals with backgrounds in healthcare administration, health information management, public health, and other healthcare related fields to complete for quality positions and contribute meaningful expertise. So why expand beyond nursing? The redesign of the quality partner role ultimately led to the development of a more interdisciplinary workforce model. This workforce brings together individuals with different educational backgrounds, experience, perspectives, and strengths. So one analogy used by department leadership compared this approach to building a successful sports team. A team cannot consist entirely of one position. Success requires individuals with different skill sets to contribute in different ways towards that common goal. So the same concept applied within quality in healthcare. So nurses provide important clinical expertise. Healthcare administrators may bring project management and leadership expertise. Health information management can contribute strong analytical and regulatory knowledge. Public health professionals can provide expertise related to that population health and performance improvement. So by bringing these strengths together, the organization creates a more versatile and resilient workforce capable of addressing those complex challenges within healthcare. What changed? The results and impact. So when evaluating the impact of the restructuring, several positive outcomes emerged. First was the standardization improved across the health system. Common processes, expectations, quality practices were all established across multiple facilities. Second, communication improved significantly. Best practices, successful improvement strategies, those could be shared more easily between the markets and replicated. Staffing flexibility improved. Centralized teams were better able to support one another during those shortages, leaves of absences, or organizational transitions. Leadership also gained greater visibility into quality performance and could allocate resources for more strategic challenges when emerged. Most importantly, measurable quality improvements were achieved. So per department leadership, Essentia Health became one of Minnesota's top ambulatory quality performers and also achieved a higher Medicare star rating than it had previously attained. And we have been able to keep that as well. So these outcomes suggest that both organizational restructuring and workforce diversification contributed positively to that quality performance and operational effectiveness. Moving forward, based on my findings, I developed several recommendations for sustaining and enhancing the department moving forward. First would be to continue emphasizing the competency-based hiring practices whenever clinical licensure isn't specifically required. Second, organizations should continue investing in professional development. Quality work is constantly evolving. Employees need ongoing education in quality improvement methodologies, accreditation standards, certifications, data analytics, leadership development, regulatory requirements constantly changing. Third, interdisciplinary collaboration should remain a priority. Bringing together diverse professionals promotes innovation, strengthens the problem solving, and helps organizations address those complex challenges more effectively. And then maintaining the specialized hospital quality and ambulatory quality structure will allow staff to continue to develop expertise while supporting those goals. And leaders should continually monitor those quality outcomes, the workforce metrics, the employee engagement, and the operational performance to just ensure that the department is remaining responsive to those future needs. So last is some key takeaways. In closing, this project examined how, excuse me, Essentia Health responded to workforce challenges and increasing quality demands through organizational redesign and workforce diversification. The findings indicate that the 2018 restructuring improved standardization, communication, accountability, staffing flexibility, and overall organizational alignment. Additionally, expanding that quality partner role beyond traditional nursing backgrounds allowed the organization to leverage the expertise from a broader talent pool while maintaining strong standards. One of the most important lessons from this project is that healthcare quality work should be defined by competencies rather than professional titles alone. As healthcare organizations continue to face workforce shortages and increasing expectations for that performance, the competency-based hiring and interdisciplinary workforce models may become essential strategies for that long-term sustainability. Ultimately, it demonstrates that healthcare organizations can successfully adapt traditional structures and workforce models while continuing to make a healthy difference in people's lives. And references. Thank you for your time, and I'd be happy to answer any questions.
Great job, Candace. I was wondering what your thoughts were on if another healthcare organization wanted to maybe replicate this in redesigning their department structure. What do you think would be a good first step for them? What would you advise them to do?
Um, First step is getting that leadership support in doing it. Depending, even if it's a small or large organization, having those key leaders there to support in that move to change is going to be big with that. Going through the change personally, it helped a lot that leaders that we were close with or respected um, were for the change and had different ways to slowly move us through or be able to feel open to ask those questions. So having that leadership support was huge,
Mhm.
not only for the employees going through the change, but also providing the resources needed to make the change efficient.
Okay, thank you.
Good
Hi,
job. Oh, go ahead. Go ahead. Sorry.
hi, Candace. Thank you so much. This is a topic near and dear to my heart because I live the role that you're talking about. A question and maybe the suggestion, exactly what you're talking about is that work should be competency based, and the National Association for Healthcare Quality, NAHQ, actually has a competency based framework. They have a self assessment tool that certainly could promote your workforce development in both assessing where staff are currently, skills, and how to advance that regardless of what your licensure or background is. So question is, did you perchance look at that?
Yeah, so we have a newly, I want to say a few months ago, new VP. She was a director within the department, so knew quite a bit. But she reevaluated our job descriptions and responsibilities and changed that senior quality partners now had to take and pass the CPHQ certification through that organization. So that is something that all quality partners on the hospital side have to take and pass, and seniors on the ambulatory quality side need to pass. So I actually just recently passed mine. So that is something that we implemented as well, and definitely a lot of regulatory things, but it covers a lot of what we work with on a daily basis, and I think will be a very beneficial certification for all of us to have.
Congratulations. Good job. Thank you.
Yeah.
Candace, I have a question for you. So there were like two major changes, right? The reorganization and then opening the doors to a more diverse teams for the quality partner role. And you mentioned that you saw a number of improvements as a result of these changes. If there were just one change made, what do you think would be more impactful?
That's a hard question. Um, I think the structure needed to come at some point. I think a more impactful one was moving the quality partner role to competency based. It was, if I look at our teams now, we maybe have two nurses between both of the teams. And hospital side has quite a few quality partners. It opened, I think it's expanded our capabilities in order to support every department within the system. Since we deal with operations, senior leadership, analytics, nursing informatics, every type, having those different skills, I think has helped us succeed even more so. I think the restructure needed to happen at some point, but the role change was, I think, big for the where we went with it.
Awesome. Thank you, Candace. Great work.
All right. Thank you so much, Candace.
Yes, thank you.
And Erin, you are up next.
All right. Here we go. Can you hear me okay?
Yes. Yep.
Right. So, as Katie said, I'm Erin Pederson. I am excited to present my capstone proposal on using an Associate Chief Medical Information Officer to enhance informatics leadership. To provide context for this capstone project, I did apply the proposed ACMIO role to a real healthcare organization, which allowed me to demonstrate how this leadership structure could address organizational needs and advance clinical informatics, specifically within the acute care setting. So we will review the organization that I chose along with its leadership structure and current state of informatics. We'll come to understand the leadership gap in the system and review key insights from extensive research that shows how informatics plays a role in acute care. These findings will bring us to the recommended solution, which is to create a dedicated inpatient informatics leadership role. We will walk through the implementation plan for this new position and how we plan to manage barriers and resistance to change. We'll conclude with final recommendations, at which time I will be happy to answer any further questions. The organization I will be referencing wish to remain anonymous, so I will be using the pseudonym Northland Health System. The organization is not-for-profit and includes one central hospital with 9 regional hospitals in addition to 30 clinics and 220 outreach sites. The organization employs over 500 physicians and 400 APPs between ambulatory, inpatient, and specialty services. They had 790,000 hospital admissions in 2025 and accrued $2.1 billion in total revenue last year with an operating margin of 2.27%. They have been using Epic electronic health records since 2007. To give some background information on how informatics has evolved, in 2009, the HITECH Act was passed, which provided funding to promote the use of electronic health records, or EHRs. This was followed by the 21st Century Cures Act in 2016, which allowed patients to become more active participants in their healthcare by making results accessible as soon as reports were available. Despite these pieces of legislation, the integration of EHRs was minimal. It was discovered that having a physician leader advocate for the EHR increased adoption by bridging that gap between the technological side and the medical side. And that's how the Chief Medical Information Officer, or the CMIO position, was created. As more organizations converted to EHRs, it created the need for clinical informatics to help end users convert the data being gathered in the EHR into usable medical practice. As healthcare becomes more nuanced with regulations, documentation requirements, insurance, billing specifications, the amount of time that end users spend in the EHR has been increasing. As beneficial as it can be to have patient information accessible at the click of a button, the EHR can often be a source of burnout for providers, especially as the number of clicks and steps in those workflows increases. So the diagram on the right illustrates the leadership structure for the informatics and IS&T teams who work collaboratively at Northland Health System. The Chief Information Officer, or CIO, is the head of the IS&T department and leads the IT strategy and digital operations, while the IS&T team is responsible for managing and building that infrastructure. The CIO works in a dyad partnership with the CMIO, who designs and implements EHR tools for quality metrics and provider efficiency. The CMIO oversees the informatics team, who are responsible for reviewing EHR tools to ensure that they promote efficiency and safety while meeting appropriate regulatory measures, as well as educating end users on Epic functionality to really improve that EHR experience. At Northland Health System, they use an Epic tool called Signal, which gathers information to see how efficiently providers are using Epic. This allows the informatics team to pinpoint areas that need to be evaluated or optimized. And then the data presented here is from over 700 inpatient providers and shows that across these 5 activities, the inpatient providers are spending more time in Epic per patient than inpatient providers do in the generalized Epic community. The greatest discrepancy was the number of minutes spent in the system as a whole, which has Northland Health at 8 more minutes per patient per day than the average Epic community provider. If informatics could help bring these inpatient providers to Epic community baseline, they could save 10 minutes per patient per day, which is really a staggering amount of time when you consider that most inpatient providers are going to see somewhere between 18 to 25 patients a day. So we know that inpatient care is becoming increasingly complex, and as organizations strive for high quality care, the EHRs are being used to track metrics, capture diagnoses earlier, and provide clinical decision-making tools to improve provider efficiency and patient safety. An essential role of the informatics team is to align the EHR technology with clinical workflows and make that EHR usable for end users. At Northland Health, the informatics leadership is led by an ambulatory-based physician, but there is no inpatient informatics specific leaders. And despite almost half of providers at the hospital being APPs, there is no APP representation at the executive level. Seeing the improvements that could be made in Epic inpatient optimization and the current informatics leadership structure, I've identified that there is a gap in inpatient leadership that needs to be addressed. So to understand how informatics leadership benefits the inpatient EHR system, we need to understand what the EHR does for acute care at the hospital. Specific tools created for the inpatient EHR can rapidly identify critical conditions, can predict risk of complications, or recognize drug-drug interactions. Inpatient care has significantly different demands than ambulatory care given the acute conditions of the patients being served, and time is often of the essence in patients who can become very sick very quickly. These tools improve efficiency for providers and ensure patient safety when they are appropriately embedded into the system. Aside from caring for the acutely ill, inpatient billing and coding relies on diagnosis-related groups, or DRGs, to classify patients into accurate panels to determine insurance reimbursement. When the EHR builds standard coding and documentation tools into notes and encounters, the EHR can improve that coding and billing with more accurate reimbursement. And then additionally, when the EHR is optimized, the system improves efficiency and productivity for providers. It improves patient safety and ultimately reduces errors. It can improve quality and reduce the EHR burden on physicians. It's clear that the EHR improves the quality of inpatient care, but simply having the technology does not ensure that the tools are adequate or that end users have the proficiency to use it effectively. The informatics team is responsible for creating tools that aid in decision-making, and having a dedicated inpatient informatics team can make sure that the specific needs of acute care are being addressed. Informaticists use EHR functionality to address operational demands and workflow challenges to make sure that regulations are met and high-quality care is being provided. They're also responsible for optimizing end users to improve efficiency and make them more productive. When there are fewer clicks and less cognitive burden, end users often experience fewer frustrations and burnout. The current inpatient informatics structure at Northland Health includes nurse and provider informaticists and inpatient Epic analysts with a CMIO as the executive leader. And then, as we mentioned, the CMIO is overseeing both ambulatory and inpatient informatics without a dedicated inpatient leader. Overall, having an inpatient informatics team is beneficial to help create that well-designed inpatient EHR system for better quality of care and improved end-user satisfaction. We've reviewed the role of EHR, and informatics in acute care, but it's also important to understand the role of the end users, and inpatient providers are within the scope of this proposal. So these providers can be hospitalists who are physicians that care for patients in the inpatient setting, or advanced practice providers, otherwise referred to as APPs. An APP is going to be defined as a nurse practitioner or a physician assistant, and their role is variable based on hospital or specialty practices. They may work independently or they could work in collaboration with a physician, but duties will generally include admitting and managing patients in the hospital setting. Most recently, the APP workforce has been increasing, which is anticipated to help mitigate that predicted shortage of 86,000 physicians by 2036. Having APPs on staff is not only cost effective, but one study of 100,000 hospitalizations showed that there was no difference in the cost or quality of healthcare being provided by a physician versus an APP. And in fact, having the APP on board did reduce physician burden and improve patient flow and throughput. APPs can serve as liaisons between patients, nurses, and physicians, and studies have also shown that they are viewed as more approachable than physicians from a nursing perspective. Some other studies have shown that APP presence in leadership has reduced nurse and APP turnover, and staff have reported greater satisfaction. APPs understand the frontline workflows and can offer diverse clinical perspectives and should be considered for collaborative leadership positions. So to summarize, Northland Health System has a solid informatics team, but inpatient leadership representation is lacking, and signal data shows that inpatient providers are spending more time in the EHR system than other Epic community providers, demonstrating the need for informatics in the inpatient setting. We've highlighted the key role that APPs play in inpatient care and recognize that there is no APP executive leadership at Northland Health. Taking that information into consideration, the proposed solution is to create an associate CMIO position that is dedicated to inpatient informatics, with the recommendation for placing a qualified APP in the position to bring a new perspective to the executive suite and generate an improved inpatient EHR experience. Under this structure, the associate CMIO would run the inpatient informatics team, but they would report directly to the CMIO, who would oversee the ambulatory EHR needs. The two positions would work in collaboration to ensure that the EHR meets the standards across both clinical settings. The ACMIO would lead the inpatient informatics team and inpatient strategic design while optimizing inpatient workflows to create more efficiencies for providers. The ACMIO would also make sure that the EHR is meeting safety and regulatory standards to improve patient quality of care. So the diagram on the left shows the proposed leadership structure with the CIO still at the head of the IS&T departments, with the CMIO reporting directly to them. And then from there, the associate CMIO would report to the CMIO, but have the oversight of the inpatient informatics team. The CMIO would have oversight over the ambulatory informatics team, and both teams would work together to make sure that their clinical settings align with the strategic vision and mission of the organization as a whole. Ultimately, the role of the ACMIO will be to advance informatics in the acute care setting by enhancing the end user experience through optimizing the EHR and driving quality improvement. This person will act as a liaison between end users and the technical team, and will not only represent the needs of the inpatient EHR, but also represent the APP and physician perspective. The associate CMIO will need to ensure that the digital tools being developed will improve efficiency and remain compliant with regulations, as they will need to provide EHR training and support for those clinical decision groups to make sure that that EHR functionality is on point. Stakeholders will need to recognize the value that an ACMIO will bring to the organization. The ACMIO will help direct the inpatient EHR to meet the strategic goals of the organization and make sure that the EHR is driving quality of care to improve patient outcomes. Financial gains of the position are going to be a little bit harder to quantify, but we would expect to see some direct financial gains from increased reimbursement as documentation and coding improve. We would also expect to see some indirect financial gains from increased access to care and increased productivity as providers are more efficiently moving patients through the system. From a workforce perspective, the efficiencies created will reduce EHR burden, lessen frustration, and overall improve satisfaction with the EHR. Bringing change to any organization can be difficult, but using Cotter's 8-step accelerated change management model can help stakeholders understand the need for that position and use their support to integrate the position into existing clinical and informatic workflows. So the first step is going to be to create a sense of urgency to establish why the position is necessary and why it's needed now. Creating a better inpatient EHR system will improve metrics, coding and billing, patient flow and throughput, and end user experience. The second step is to build a guiding coalition, which includes a dedicated inpatient informatics team comprised of key stakeholders such as nursing, provider, pharmacist, and the IS&T team who champion and support those changes. This will help gain buy-in from the organization, and those team members can help design the necessary EHR tools. Step 3 is to form a strategic vision and initiative, which we really have previously outlined. The ACMIO will be managing the inpatient EHR design while working collaboratively with the CMIO. Clearly defining the roles and responsibilities of the ACMIO will help stakeholders understand how the position will help achieve those planned initiatives. And then step 4 is to enlist the volunteer army. By creating a specific inpatient super user program, the associate CMIO will gain end user perspective and can be used to promote a positive image for the EHR to other end users. Step 5 will be to remove barriers that could prevent successful implementation. For this specific role, it will be necessary to highlight the benefits of having an APP in the ACMI role and the direct and indirect financial benefits of creating the position, such as efficiency and improved reimbursement. Step 6 will be to generate short-term wins to provide measurable early successes that will demonstrate the value of the ACMIO position and build momentum. It will be beneficial to use the super users to identify pain points and then make small adjustments to reduce some EHR burden and show the value of having a dedicated inpatient informatics team. Step 7 would build on step 6, and it would expand those quick wins into more sustainable improvements, and then broadening those optimization goals to create more system-wide value. Step 8 is to institute the change by embedding the ACMIO into executive leadership and culture so that it becomes a sustainable position. Continuing to use stakeholders to demonstrate the value of the position through data and outcomes will promote the value of the position and reinforce that change. Using the Cotter method, the implementation timeframe for the position would be roughly 18 months. The first 3 months, we'll use steps 1 through 4 to prepare for the new role and make sure that the organization and the stakeholders are in alignment with that strategic plan. Between months 3 through 6, the role will be implemented, and then creating a sustainable position and institutionalizing the change would occur over the next 6 to 18 months. Naturally, there will be some resistance to change, the amount of which really depends on the cultural climate of the organization. Using the ADKAR model, the organization can overcome skepticism to the position and enhance the implementation plan. Creating awareness of the role and its duty to the organization will help justify it. Creating desire by garnering support from leadership and promoting the benefits of the role will create buy-in by highlighting the rationale and expectations. Dispersing knowledge of how the position will change the organization will be essential and may come from informational sessions to share the expectations of the role and understand how that leadership structure will operate. Additionally, giving individuals the ability to use the knowledge that they gained about the position and apply it to the work they do is going to validate that role. So that's going to require workflows that need to be created for individuals to utilize the ACMIO to address their inpatient needs. And then finally, reinforcement needs to coincide with institutionalizing the change in the Cotter model, making sure the ACMIO is embedded in the organizational leadership structure and as a visible advocate for the inpatient end user needs to be essential. Sharing initiative outcomes and metrics will help demonstrate the value of the position and reinforce why it's necessary. There are 6 metrics that should be used to measure the success of implementing the ACMIO position. Quality metrics need to be monitored, and designing the EHR to provide evidence-based prevention practices to identify high-risk patients and to recognize patient deterioration will be necessary. The EHR can improve safety metrics by creating decision support tools and closed-loop safety processes to prevent errors in medications, diagnoses, and blood transfusions. The EHR can improve hospital efficiency and utilization by identifying barriers for discharge that will affect length of stay and better tracking of bed occupancy, which will improve wait times for inpatient beds as flow and throughput is optimized. Epic signal data will be used to measure EHR efficiency, and the goal, again, will be to get inpatient providers to the baseline of other Epic community providers. Northland Health currently uses 2 different surveys to track employee and patient satisfaction. Class surveys are distributed by a third-party system and are used to assess end-user satisfaction with the EHR. So the recommendation would be to distribute a survey prior to the ACMIO starting, and then every 2 to 3 years to monitor progress. Press Ganey surveys are distributed with every patient admission, and the recommendation would be to monitor those surveys for improvements in care coordination, communication, and discharge information. And then lastly, direct financial metrics can be measured by monitoring the cash collection as the number of insurance denials decreases with improved documentation and coding. And then indirect financial metrics could be measured by tracking preventable errors and provider productivity. So in conclusion, clinical informatics plays an essential role in effective workflows and EHR optimization as providers and end users become confident in the EHR and can treat their patients effectively and efficiently. Inpatient APPs serve an important role in the acute care setting by improving quality of care, acting as liaisons, and reducing the burden on physicians, but they do lack representation at a leadership level at Northland Health. Northland Health currently operates under a physician CMIO with an ambulatory background, but has no dedicated inpatient informatics team. Creating an inpatient associate CMIO position led by a qualified APP would improve EHR optimization, quality metrics, documentation, resulting in direct and indirect financial gains. Implementing the ACMIO position will require using Cotter's 8-step model and the ADKAR model to overcome resistance to change over an 18-month period of time. This proposal provides the Northland Health System with a framework that can adapt to meet the increasing complexities of inpatient care and support APP growth in organizational leadership and should be considered by similar organizations as well. I have several references, and then I am ready to take any questions.
Great job, Erin. My question is, so you had listed a bunch of metrics that would demonstrate evidence of improvement and value and things, but which of those do you think would be the best early indicators, or which metrics do you think would provide the strongest early evidence that this role is adding value?
Yeah, I think probably the signal data, which is tracking provider efficiency. I think that one we could see improvements probably the most quickly. I think the other metrics would probably take, even years sometimes to see the full benefit. But it's something that the organization does already when we optimize providers, and then we look at their signal data within 3 to 6 months to see are the changes that we've helped them with improving their efficiency in the system. And as those providers become more efficient, they do experience less frustration. They have less EHR burden, which is really becoming an increasing problem in a lot of organizations. So I think kind of getting providers and end users optimized that way will improve their EHR experience, but then being able to move through patients more quickly, being able to spend less time in Epic per patient, maybe they can see 1 or 2 more patients a day, and that would be significant when it comes to managing that patient flow and throughput in a hospital setting.
Great, thank you.
Yeah.
Hey, Aaron, great job. This is also very timely. I have a research work group that we evaluate workforce changes in the informatics profession. And just yesterday, we had a meeting where we talked about doing a study to look at the skills and competencies that are required of the CMIO and an associate CMIO positions internationally.
Okay.
So that's very, very timely. So I might have to have some conversations with you
Yeah,
here in the near future. Um,
absolutely.
but something that came up in our conversation was the tendency that when you have a clinical professional who often would be working in that department
Hmm.
fill a leadership position, they serve these dual roles then, right? They're like, yep, you're gonna maintain your clinical
Hmm.
role, but you're also gonna do this other stuff.
Yep.
And then the uh building the rationale potentially for like additional money, but a budget for analyst, IT staff, maybe even backfilling that clinical position. If you had to prioritize, let's say one or two things to ensure that that role is successful, what would you justify as the most important thing to invest in with that role?
That's a good question. Honestly, the things that I spend the most time on are educating end users on what's available. So I do think investing in not just this a CMIO or an associate CMIO, but investing in provider informaticist, nurse informaticist, um, to be able to do more one-on-one trainings. Providers don't read their emails. They rarely have time to go to extra meetings. But I find the most use in my job when I'm able to catch a provider in the hallway and say, hey, do you have a second? I want to show you this one thing. And the number of times I have people that come back to me and say, hey, you showed somebody something, and now I want you to show that to me too because they love it. So
Mhm.
having more people be able to get out there and be able to interact a little more one-on-one, I think is one area that I would really invest in. Um, and I think the organization as a whole really needs to think about what the strategic plan is for inpatient care. And I think sometimes we just lose sight of like what are the important things that we need to focus on. And maybe it's patient flow and throughput. That's a huge topic right now. So maybe investing in educational classes for our super users or for our informatics team to really understand what are other organizations doing and how can we incorporate that with our leadership, because I feel like there's a divide between,
Yeah,
medical leadership and informatics leadership.
great. Thank you, Aaron.
Yeah, no problem.
Hey, Aaron. Yes, very interesting discussion relative to the increasing role of APPs. And I'm familiar with a lot of what we did in the VA relative to the federal legislation to have APPs practice to the highest level of licensure, including that nurse APPs were credentialed and privileged. And so I guess a couple of questions and then maybe some thoughts for consideration. So I'm not sure in your state whether APPs are credentialed and privileged, and how the role of maintaining clinical competence, as was previously suggested, enters into the role, and whether you are envisioning that full-time, part-time, and at what, and how that would work relative to maintaining that clinical competence, which is a lot of that knowledge of what they would bring to the role relative to inpatient documentation requirements, etc., and how to add the additional knowledge that they might need relative to the metrics and other processes that are beyond their other clinical roles, and just some things that you might want to think about, or have you considered that within the processes? The
Yeah.
one last thought is that in the role of APP, nurse practitioners have a different role and function and clinical bent than physician assistants. And so whether you would consider alternating the role of that, or whether that is a permanent position, or how to ensure both perspectives are ensured. That's all.
Yeah, no, those are really good points too. And I would envision that this role would maintain some level of clinical work. Typically, it's going to be, like anywhere from a 0.5 to a 0.8 for a leadership role, and then the other roles will be covered by your clinical work. And I'm not as familiar with nurse practitioners and what they need to do to maintain their credentials. I would assume it's fairly similar to physician assistants, needing to maintain so many contact hours. For physician assistants, it's making sure that you are completing all of your CME courses and that sort of thing. So I think by maintaining some of that clinical work, I think that would cover it. You also had a very good point. Nurse practitioners and physician assistants are different. They're trained differently, and they can operate a little bit differently within an organization. For this particular organization, they work pretty jointly. They're usually utilized the same. And so in this role, I think, having maybe if let's say your associate CMIO is a nurse practitioner, then making sure that you have a PA as one of your provider informaticists on your inpatient team, or vice versa. I think that would be one way to make sure that you are keeping appropriate stakeholders involved so that you are getting perspectives from both sides.
Great. Thank you, Erin. Any last comments or questions? All right. Thank you so much. Hallie, you're up. Perfect.
All right. Can everybody hear me okay? Okay. Thank you, everybody, for joining tonight. I'm glad everyone stuck around for the last presentation of our 3-year process. Today I'm going to be, my name is Hallie Pittsley. Today I'm going to be discussing the opportunity to improve rural primary care efficiency through workflow enhancements. And So roughly about 14% of the U.S. population lives in rural communities. Organizations serving them contend with persistent challenges with workforce, resource constraints, barriers to access, and continually rising demand for primary care services. Tamarack Health Hayward Medical Center has set a goal to improve healthcare options for the community and the surrounding areas by introducing primary care into Tamarack Health System. The following will focus on how HMC can continue to support the growth of primary care while addressing the operational challenges that have developed with this growth. By shifting towards a proactive healthcare maintenance plan and standardized pre-visit planning, the goal is to improve patient flow, ensure laboratory testing is completed appropriately and efficiently, and create better experience for patients, providers, and supporting departments. In 2022, HMC started a primary care clinic with 2 providers. This was a brand new service for the organization and a completely different workflow style for multiple ancillary departments, such as lab. By 2025, the organization grew even more, up to 9 providers, and is expected to continue to grow with up to 20 providers in total. The current patient visit process involves performing chart scrubbing on the day of the visit. This process has caused multiple issues, including a lack of lab orders despite a lab appointment, lack of prior authorization for radiology needs, and overall a patient visit with multiple gaps in care. Because HMC is rural, ensuring access has been top priority. which means getting the patient lab testing performed on the day of the provider visit to avoid additional transportation for care. However, without the patient's chart being reviewed and corrected, and with proper orders in place, this process causes delays in care from the start of their visit. Current visit processes contribute to workforce strain, delays in care, inappropriate or poorly timed laboratory testing. With constraints that rural healthcare has, inefficient workflows are especially difficult to absorb. The impact of inefficient workflow and processes will continue to affect the current patient care flow unless recognized. As growth continues, these challenges begin to affect other aspects of care beyond workflow. These inefficiencies place additional demands on limited resources and can affect the overall experience for patients, providers, and supporting departments. How can HMC make primary care visits more efficient while using limited rural resources responsibly? Based on the literature review, 4 key insights popped out to me. The first one was standardized care. This is the use of evidence-based workflows and laboratory protocols for test ordering that can assist in improving consistency, efficiency, and appropriate utilization of laboratory testing. Standardized workflows can be developed based on specific healthcare needs. Pre-visit planning, this was preparing patients and completing necessary testing before provider visits can reduce delays in test results, improve workforce utilization, enhance the value of the appointment between the patient and the provider. Collaboration, strong collaboration and communication between primary care services, lab, and patient supports coordinated patient-centered care. Laboratory stewardship improves when appropriate tests are used to reduce unnecessary or duplicate testing while supporting quality of care and responsible use of resources. Also, lean improvement strategies can identify workflow inefficiencies and support sustainable process improvements as organization needs change. Literature frequently demonstrated that efficiency is not achieved by changing only one department. Standardized processes combined with collaboration among primary care, laboratory, nursing, and other departments create a coordinated, sustainable approach to patient care. Since approximately 70% of clinical decision-making is based on laboratory results, it is important to ensure that there's time for the patient to obtain testing before the provider visit, and that lab orders are available for the lab visit. When processes like lab test ordering are standardized based on the patient's healthcare maintenance plan, the clinical team knows which tests need to be performed before the patient's provider visit without involving the clinician. This process will decrease the number of lab appointments that do not have orders, improve the patient's visit by creating a seamless visit without barriers, provide the lab time to make sure testing is performed and completed before the patient's visit with the provider. This standardization requires collaboration with the provider and the lab to determine standardized lab protocols, collaboration between lab and patient care team for patient-provider scheduling, and lastly, collaboration between the provider and the patient to determine the type of healthcare plan needed. Pre-visit planning shifts the care from a reactive approach to a proactive approach. It assists with identification of testing needs before the appointment, allows for results to be available at the time of the visit, and assists in reducing delays and errors. The lean approach focuses on elimination of waste, workflow evaluation, improves work efficiencies, and promotes continuous improvements. Pre-visit planning and lean principles complement one another. Pre-visit planning moves necessary work earlier in the process, while lean helps identify steps that add no value. Together, they can improve patient flow, make better use of limited resources, and enable provider visits to focus on outcomes, decision-making, and patient needs. The expected deliverables of the project is a standardized patient-centered workflow designed to improve coordination between primary care and laboratory services. Proposed model combines the healthcare maintenance planning, standardized protocols, and pre-visit planning to prepare patients and ensure necessary testing is completed. The proposal also suggests the introduction of an additional position, a pre-visit planner. This pre-visit planner will be available for the patient, providing pre-visit chart reviews, build the connection with the patient, and identify any gaps in the patient care. The provider and clinical team can then focus on other patients during this time. This process will provide advanced information for the provider-patient visit and ensure that there's no roadblocks or delays during the visit. The proposed pre-visit workflow starts with the patient and provider's first meeting. During this visit, the patient and provider will determine healthcare maintenance plan that suits the patient. They will have time to discuss the expectations and develop an initial relationship. The pre-visit planner would then start to review the provider schedule about 2 to 3 weeks in advance to determine which patients that have upcoming visits need to be contacted before their appointments. During this time, the pre-visit planner will review the patient's records for anything that is missing, ensuring that any testing needed is authorized by the provider, deal with any prior authorization needs for any kind of specific testing. About 1 week before the patient provider visit, the planner will contact the patient to discuss any needs for the visit, to prepare the patient for the visit, and together they will coordinate the patient's testing and timing. Then it comes time for the visit. Due to the planning in advance, the provider and the patient have more time available with each other to go over results and ensure that they are on the same track for their healthcare needs. Implementation would be the utilization of lean concepts tailored for the needs of complex organizations such as healthcare. This process will be carried out in stages. The main process, which would probably take approximately a year, is the first phase. This focus will be on ensuring the correct people are involved in the planning of the project, protocol, and possible new role positions. The first goal of the group is to ensure a clear definition clear definitions of the project roles and possible outcomes. This includes members from primary care, lab, radiology, registration, and other key stakeholders. During this phase, the team will establish standardized protocols for patients, specifically for annual wellness visits will be the main focus, and define the role of the pre-visit planner position. Once the standardized protocols have been established and agreed upon, and other providers have been involved in the discussions, upper administration also has approved the process. The rollout will begin. During the rollout, it will be with one provider team. This provides the organization an opportunity to test the process, identify any workflow gaps, gather feedback, and make adjustments before moving forward. Once the pilot has worked effectively, the model can then be expanded throughout primary care teams. The important part is that the implementation does not end with expanding. There should be continuous monitoring of outcomes and adjustments to the workflow as patient volumes change, staffing levels change, and other advanced opportunities in healthcare arise. Continuous monitoring of the process will occur along with the use of measurable metrics. Although the proposed solution offers opportunities for improvement, implementation within a rural healthcare setting presents several barriers. Limited staffing and resources, resistance to workflow changes, technology needs, and variation in provider practices can affect standardization. Patient access must also remain consideration, particularly when pre-visit testing could require additional travel. For this reason, implementation needs to remain flexible while still promoting a standardized approach. Identification of barriers early, which will allow the organization to adopt the process rather than abandon the process when challenges occur. How will success be measured? With the use of baseline trends, the success of the process will be determined from the monitoring of the pre-visit work completion, percent of lab tests that are available before the provider visit, lab test results that are available before the provider visit, evaluation of laboratory wait times, distribution of the appointments across the day, decrease in double bookings, stewardship of laboratory testing with monitoring of duplicate testing that was collected at an inappropriate time frame. As many people know, with annual wellness visits, you have 1 year and 3 days for a TSH before it's reimbursed. And monitoring and the compliance with the standardized protocols of the lab ordering. Patient satisfaction with a focus on wait times, communication, and visit quality, as well as employee satisfaction on feedback on efficiency and burnout. Key takeaways of this project, efficiency depends on designing workflows around the workforce, but not adding more work. Standardized protocols based off of evidence-based protocols. Pre-visit planning shifts the patient preparation to include the patient for a more patient-centered approach. The planner performs all of the coordination without adding additional burden to the clinical team. Successful change requires engagement, a provider champion, clearly defined roles and responsibilities, and continuous monitoring for improvement. Improving rural primary care efficiency does not require a single major change. Rather, it comes from creating standardized, proactive, and collaborative processes. Pre-visit planning provides an opportunity to coordinate care before the patient arrives, while lean principles help to ensure that each step adds value to the patient's care. Most importantly, the process must remain flexible enough to meet the unique needs of the patient and the organization's resources. Improving efficiency does not necessarily mean adding more staff or resources. It means looking closely at how the resources are already available are being used. The project demonstrates an opportunity for HMC to move from a reactive process to a more proactive model of care. With the combination of healthcare maintenance, pre-visit planning, appropriate test utilization, and collaboration, patients can arrive better prepared and providers have the information needed to make meaningful decisions during the visit. This is not intended to be a rigid process. With the use of lean principles and continuous evaluation, it can adapt to current needs and trends. Overall, the goal is to create a sustainable primary care model that uses limited resources responsibly while improving the experience of the patient, providers, and the overall healthcare team. I talked a lot faster than I wanted to.
Thank you, Hallie. David, go ahead. You asked first.
All right, Hallie, good work. So I have a question, more of like a process question. So in with at Tamarack Hayward, do you when there's a laboratory order, is it required that a patient have a lab visit scheduled?
Yes.
So
So
how would you manage that like that process, and could that create like some upstream bottlenecks, let's say, with scheduling if people aren't doing their labs same day of the appointment?
it does actually cause a lot of issues and the reason why they have to be scheduled is 100% due to the fact that we're a rural healthcare association. So for billing purposes, lab testing has to be on a hospital-based billing system. So we can't do any lab work without having it on the schedule. But our current process that we have in place is that if there's a patient that just, the provider drops off at our checkout and it's supposed to be like a lab after visit, our checkout person creates the scheduled appointment. If it's something that, this is where the pre-visit planner would come in, is that when they know that there's labs to be collected before the patient arrives, the pre-visit planner will ensure that that appointment is scheduled for the laboratory to know what needs to be done. Right now we're having patients being placed on the schedule because providers are not providing lab orders because they want to make sure that they have a spot on the schedule, which requires back work on the lab's end to do chart scrubbing on our own to look for lab orders, to wonder, why does this person on the schedule? Is this person going to show? That kind of thing. And it has caused backlogs with double bookings and walk-in visits.
Okay, Ellie, that was really good background because that like totally clarifies the intent behind what you've done as well. I mean, it was very clear from your presentation, but that additional information was great. Thank you.
And Hallie, I was just wondering who you envision, or the type of maybe background would serve as this pre-planner in this position.
I envision like certified medical assistant type person, CMA utilization, or even a nurse assistant type person. One of the research things I was looking at actually put it up to more of a bachelor's style, like kind of like an APP, kind of putting in that position because then it gives them more available, more conversation with that. But with our experience at our facility, the CMAs have a really great rapport with our patients. And that creates this one-on-one environment for them, and they get comfortable with that person that they talk to. So someone who has enough background in healthcare, has enough background in organizing and helping patients through things, as well as know where to send patients with their questions, is pretty much what I would believe is required. And I think a CMA role would help with that. It is very difficult with rural health to get nurses. It's very difficult to even get the APPs or anything like that. But we actually have a CMA apprenticeship program that we started at Hayward. And so with that program, we've been pulling in the community to try to engage the community to basically, if we can grow them from within, they'll stay. But if we pull them from outside, they tend to leave us,
Yeah,
unfortunately.
it's understandable. Thank you.
Haley, I just want to commend you on using lean methodologies, looking at the waste that you've actually identified in the system with wasted appointments, double booking, wasted delays, and the overutilization of other services when patients can't get to primary care, and how that challenge that you've identified is really prevalent in so many other systems as well as rural, but good job.
Thank you.
All right, any other comments or questions? All right, so with that, just a couple things.
Yeah, let me mention one thing.
Yeah, go ahead, David.
I have to tell everyone I have thoroughly enjoyed working with all of you on your capstones. I'm very familiar with most of the areas, but from every one of your presentations, I have picked up something new that I really appreciate and enjoyed working with you on that. It's been really nice to sit in on your presentations because I could see how you've developed that over time in your papers. And very nice job, very professional job. Pleasure to work with everyone. So thank you very much. And congratulations.
Thank you, David. You all did a really great job. I'm really impressed as well. I just want to conclude by saying, David touched on this last night as well, but we really do want you all to stay in touch with us as you graduate and move on in your careers and things. And so don't forget about us. Keep in touch through our alumni receptions and networking and those events that come up, Latour Eichenwald Forum, things like that. And so hopefully we'll see you at ACHE events and different things as well. Let's see what else. I mentioned last night that I do have an email into our librarian for the Stender School to talk about if you want to look at publishing your capstone projects in our database. And so hopefully I'll be hearing from her. She had to verify a couple of things before she gave me instructions for all of you. So hopefully I'll have information about that over the next couple of days. So David, Mark, any final things from you?
Just a congratulations. I agree to what Dr. Swenson had said regarding just learning something new with each of your presentations. And I really enjoy hearing the work that you've done. And certainly it's clear that you are all models to whom we want to engage in this program in the MHA and healthcare administration profession at large. And I have no doubt that whatever your passion, goals, ambitions are, that you certainly will be successful. So give yourselves a big pat on the back.
Yes. Well done. Congratulations, everyone. And with that, I'll let you all go. Thanks for your hard work and really good job tonight.
Thank you. Congrats.
Thanks.
Thank you.